Hi, I'm Stephanie Shelton, and this is Conversations on Health, How We Get There, episode 16. We're talking about drugs in this episode, often life-saving drugs. And we humans are living longer in many cases because there have been so many breakthroughs in fighting disease. But as anyone knows who's been to a pharmacist window lately, these great new drugs are expensive. And in the United States, they're often not covered or poorly covered by insurance. And sadly, in this rich country, some people actually have to choose between the drugs they need for their disease and feeding their kids or themselves. I'm sure you have the same questions I have, and they all start with why. So I asked Alan Weil to come on the podcast and do some explaining. Alan has a long background in healthcare policy and healthcare policy journalism. He's been editor-in-chief of Health Affairs since 2014 and is the podcast host of a Health Podyssey, where he talks with leading researchers shaping the big ideas in health policy. I talked with Alan a few weeks ago via Zoom from Prague in the Czech Republic. It turned out to be a very thoughtful conversation. Alan, welcome to the podcast, and thank you so much for coming on.
My pleasure to be here with you.
So let's get right to it, because this drug pricing issue is it's so complicated, and people are so upset about it. And I read every day about somebody who doesn't have the money to pay for his or her drugs, cutting pills in half or just skipping doses completely. And that should not be happening in the 21st century in a country like ours. So in general, why are drugs so expensive in this country when you can go to any other country in the world and get them for half the price?
Well, I think we have to start with the notion that we treat prescription drugs in the United States as a market commodity. There are manufacturers, there are distributors, there are sellers, and they're for-profit, profit-making organizations, and they're motivated by making decisions that will maximize profit just as any other business operates. And that leads to practices that are inflationary, I would say, to the consumer. It also leads to a lot of public policy manipulation designed sometimes to try to reduce prices, other times to try to increase profitability. And one of the things that the industry has been very effective at in the United States is convincing a large number of policymakers in particular that the drug innovation that we have, which of course we all benefit from when drugs are affordable, is only happening because of the large profits that can be made on successful drugs to offset the investment in drugs that don't make it. And there's a lot of reason to be skeptical about the details of that argument, but the general notion that it's a market commodity, we should maximize profit, or companies that are involved in manufacturing distribution should be permitted to maximize profit, and that those profits are necessary to continue discovery. That ecosystem is one that perpetuates high prices.
Well, you could argue, I suppose, that they could make that same argument to every other country, to the rich European countries. And they apparently don't, because where I'm sitting now in Prague in the Czech Republic, it's a state-run, like all European countries, state-run healthcare system. And I know a friend in America who's getting a particularly high-priced drug, and a person here who's getting that same drug and not paying a penny for it.
Well, that gets at two dimensions that I think it's important to keep in mind. One is the pricing of the drug, and the other is the cost to the patient of the drug. And those are related, but they're actually quite separate. So the pricing, as you mentioned, we have markets setting prices by and large. Again, there's lots of distortion in them. But the European countries, as you referenced, they negotiate prices. And of course, we're starting to do that in Medicare here in the United States. We may talk more about that depending on where this conversation goes. But we're beginning to experiment with the idea that the largest payer for drugs, Medicare, should take an approach that has something in common with the approach that's universal, really, around the world. But the second topic is what you pay. And of course, in the United States, and as in any country, what you pay is the price minus whatever your insurance will cover. And insurance design around prescription drugs is also highly variable. And so I think if we're talking about affordability, we're looking at both the underlying price and how insurance pays for it.
I've had experience where, and this is particularly people who are on Medicare, so they pick a drug plan, a Plan D plan, and you pick it in the beginning of the end of the year, actually, and you have no idea what the next year is going to bring. And they get something or they develop something, and their insurance company doesn't cover the drug. So sometimes they can get it for something off, but they can't get it for what they find the next year. Another insurance company pays for it. And, that insurance company may be a reasonable price. It just seems, and that to me is just another roadblock for people. Why shouldn't you be able to change insurance companies, change drug companies when there is a reasonable reason to do that? And wouldn't that ability at least allow people to make use of what they're paying for, which is insurance?
Oh, there's so many topics in that very simple seeming scenario in question. So first of all, I actually think the story that people have been told, which is you should pick your Part D plan by looking at the drugs you're taking, matching it with the best plan and the best coverage. That's not really an insurance story because you don't know what's going to happen over the course of the year. When you're picking an insurer for your car, or for your house, or anything, you should really be looking overall at whether or not it meets your needs, the price matches what you can afford. And this notion of sort of lining up exactly what I'm taking with exactly what's covered, it's setting people up to fail. But that also ties into two other issues raised by what you described. And one is the proliferation in the United States of what we call pharmacy benefit managers, or PBMs. Because prices are so high and because we use markets to set prices, there's this whole layer of middlemen organizations that negotiate with the manufacturers to try to get the price down. And in order to get the price down, they have to promise a higher volume of purchases. And that, how do you get more purchases of a certain drug? By modifying the benefits in the insurance plan so that if you take drug A, which is a preferred drug, your copay is $10 or $20. If you take drug B, your copay is $100. Well, most people are price sensitive. They're going to go to drug A. That's going to increase the volume of A. That gives the PBM more leverage to negotiate a better price. Those kinds of dynamics, again, only exist because of the market structure that we have where volume drives price. If you have negotiated prices, those kinds of things go away. And then the last thing I would say is your comment about changing insurance mid-year. I mean, I think insurers in general, that there's a phrase that you can't buy insurance for a burning house. I mean, the concept of insurance is paying in advance into a pool, and you need what you need, but in the years you don't need it, someone else needs it. And so I think it's not, to me, the fix for the problem you're describing is less letting people change insurer than sort of changing how we do some of the pricing so that you wouldn't need to change insurer.
Or each insurer should cover every drug. I mean,
well, but again, if they cover every drug, then they lose their leverage and the prices go up. So there are lots of rules about covering at least one drug in certain classes. But again, in a market where you're trying to compete, the way to compete is to drive volume, and the way to drive volume is to limit choice. Even, and just to be fair here, when you say you're in a, European country that negotiates prices, um, one of the consequences of that is that not everything is available. It's just that's not visible to you at the moment of purchase because the negotiator's decision was made long ago in a room that you weren't in that says we're going to cover drug A and not drug B. And that's sort of the end of the story. So the somewhere in the process has to be the ability to exclude, or else, again, you have no leverage to get a lower price.
Well, what is actually, I mean, to be fair, as you say, a drug company, just because they manufacture something that saves people's lives, they're still a company, and they'll go out of existence if Wall Street, decides that they're not making enough money, which is another issue entirely. But what is fair to a drug company? They do put money into research, and that research often turns out to be nowhere. There was a trial that was just dropped about 2 weeks ago. I don't remember the drug or the company, but the trial was going nowhere, and they stopped it. And that was 10 years worth of research down the drain. So what's fair?
Yeah, I don't think anyone can give you a perfect definition of fair, and I'm sure people would view it differently from the company's perspective, from the patient's perspective. I think we would all agree that there should be fair returns. I do think there's and there are people who are much more expert in the pharmaceutical discovery process than I am, but much of the basic research is publicly funded. It's in the United States, the National Institutes of Health funds the original discovery. What's often very expensive, as you mentioned, is the trials, the stage where once you've gone through the discovery, you take it out and determine safety and efficacy and the like. And there clearly are risks there. There have been myriad proposals by all kinds of experts to try to figure out how to um, appropriately reward the risk that those who are conducting the trials are undertaking, while not just letting them maximize the return on it. So I think there are plenty of ways to think about a structure that would encourage discovery and allow these businesses, which they're businesses, to thrive and be profitable without some of the excesses that we see. There's also global distributional decisions here. I mean, as you mentioned, there's no reason other high-income countries other than the United States couldn't carry a larger share of the cost of development. It's not as if the US is the only country that has the income to support drug discovery, but it is the country with the least political will to constrain drug prices. And so it's very lucrative for the industry to make large profits in the United States, and therefore they're under as much pressure to make them in the rest of the high income world, and that seems pretty problematic.
Well, there are drug companies that are not ours, that are seated in Europe, and they survive. And I know this is not your area of expertise, and I don't know anything about it either, but obviously they work out some different agreement because they still come up with new drugs.
Well, that's right. And much of what we're also describing here, it's very interesting because when we talk about drugs, of course, there's so many different kinds and types. And loosely in the US, you would divide between branded drugs and generic drugs. And we have a very robust, it has its flaws, but we have a very robust generics market. And when a drug goes off patent and becomes available in the generic market, if there are multiple generic manufacturers, the price often drops a 1/3, 2/3 over a period of years. And the more generic manufacturers there are, the more the price comes down. And the vast majority of drugs purchased and consumed in the United States are generics at much lower prices. The vast majority of the profits are associated with the branded drugs. And then, of course, we have these very high-cost specialty drugs. We have infusibles, we have the advanced cancer therapeutics, we have CAR T therapies that are, highly specialized, and it's all of those together that sort of create the financial system that supports the industry. But from a consumer perspective, those are all really quite different things.
Yes, and from a consumer perspective, the average person doesn't care. The average person doesn't want to be sick, goes to a doctor, gets a prescription, goes to the drugstore and says, "Are you kidding?" And many times walks away. I have seen this. I've seen a pharmacist say, "Wait a minute, I'll look up GoodRx or something.
Yes.
There's a coupon that can help you and help a little bit." But I've actually seen a woman saying, "I don't have that kind of money," and turn her, almost in tears, walk away. That's a hard thing to see when you know, yeah, not every drug is covered in other countries, but for the most part, if you really, really need it, you get it.
Many of the stories are heartbreaking and really unacceptable and unforgivable in a country like ours. And there's a continuum here of sort of misinformation or poor information where the prescriber doesn't do a good job of checking the benefits, or the pharmacy is unable to find an alternative that is within the list of preferred drugs for someone's insurance, or they're uninsured and they're at the mercy of the market. And I mean, again, it's the piling on of so many dysfunctions. It's a profit-driven system. It's a large number of people without health insurance at all, which of course is not something you see in much of the rest of the world. And then it's these benefit designs that are skewed very heavily to make it desirable to or more affordable to purchase the drugs that the benefit manager is trying to drive the traffic to. And then you've got to figure out, will that drug work for this person? And if it doesn't, the prescriber has to go through all sorts of hurdles to try to get a drug on the list that was initially excluded. I mean, the system is poorly designed, and at the worst end, absolutely. We've published papers in Health Affairs. One of I think one of our more interesting papers a couple of years ago was about the high number of people who would leave behind cancer drugs that were prescribed. They simply could not afford them. And the notion that someone with cancer, where there is a drug that could likely help them, simply doesn't take it because of cost is really horrifying.
It is horrifying, especially now, and especially when you know the advances that are being made, and you begin to wonder, if you get something, can you possibly afford having it? But I did see one study when I was doing the prep for this, to the effect that there have been too few studies done about drugs that are similar and their cost price that doctors have seen, so that a doctor is not really familiar with the alternatives and whether they would work for this patient, and so doesn't even try to prescribe it. He just prescribes what he knows best, and what he knows best, or she knows best, is the most expensive brand name drug if they can get it. So would that help a little bit if there was more of that done? And that's kind of in your area.
Yeah, it definitely would help. And so there are a few elements here. And the first is there's been significant political resistance to what's referred to as comparative effectiveness research, which is exactly what you described, comparing the effectiveness of different drugs. The standard medical comparison is to placebo. Is this safe, and does it do better than nothing? Putting drugs up head to head is part of the infrastructure that countries use to do the selective contracting that enables them to drive down price. Historically, the pharmaceutical industry has had allies in Congress that have been, because they're opposed to those kinds of contracting approaches, they view comparative effectiveness as a critical input to the negotiation. So if they can block comparative effectiveness research, they block the ability of negotiation. And so they've sort of gone upstream and reduced the evidence that we have to enable us to make the kind of decisions you mentioned. You also, another factor here, you mentioned the prescriber. There is this practice of detailing. I mean, there's, and of course, in the United States, we have you can't watch a TV show without seeing half a dozen advertisements for pharmaceuticals. So we have very aggressive marketing direct to consumer, and we have very aggressive marketing to clinicians, to prescribers, to convince them of the merits of the new drug. And I would be remiss if I didn't somewhere in this conversation also mention the lengths to which the industry goes to prevent generic competition. So as I noted earlier, generics drive down the price by often more than half. The longer you can hold on to your patent or delay that kind of competition, the longer you can make the money that you make on the branded drugs. And the industry has been very effective at manipulating the law to extend patents by making essentially trivial modifications to the drug or how it's delivered. They've bought off generic companies to tell so-called pay for delay to prevent them from trying to enter the market. There are all kinds of ways they can litigate that delay entry, and these are worth billions and billions of dollars. And this is all tied back to the notion that the companies are trying to make money, and these are techniques that they can use, and they come at the expense of the consumer.
Okay, so another issue about the drug advertising, which is the, ask your doctor if this drug would be good for you. So a consumer who sees this on and a lot of times it's the evening news, which is aimed at older people because they're the last people with cable TV or TV period. So they walk into their doctor's office and said, I saw this drug, its name is blah blah blah. Wouldn't that work for me? It sounds like it's me. And the doctor says, I don't really think so. And it's kind of expensive and you don't really need that. This one you're using is just fine. And the patient says, but, shouldn't I have the best? And that said, the commercial said it was the best. And the doctor says, no, you don't need it. And the person gets up, walks out of the office and goes find another doctor who will give her the medicine that she thinks she deserves. Is that is that a drug advertising issue? We didn't have drug advertising until 1983, something like that?
I am sure the scenario you described occurs. I don't think it's the biggest problem we face in our health system. And there have been issues raised about all sorts of medical conditions and procedures that are not advertised or that are not drugs, where a patient may think that they need something and the doctor they see says you don't, and they might go to someone else and get it. That can happen with surgery as easily as it can happen with a medication. And of course, we don't see a lot of advertising for surgery. Doctor shopping, as with anything else, is something we would want to be careful about. I'm not going to pin the problems of healthcare on the overzealous consumer who's been swayed by the commercial that whatever they're getting isn't good enough for them.
All right. The other issue that may or may not be linked to advertising in general, but do we have a situation in this country, and again, this gets back to expense, if the average person over 55 takes 5 drugs, as one doctor once told me, and I've seen that a few other times, might there be some doctors who prescribe too many drugs for their patients instead of lifestyle changes and exercise and things that cost very little but might preclude the necessity of taking a drug? And, I don't want to get into the weight versus diabetes, issue at this point, but just in general, it seems that there are ways to lower cholesterol without taking a drug, unless it's really, really a bad situation. There are ways to lose weight. There are ways to improve your digestion, stop eating hot foods, whatever. And we don't do any of that.
Well, I don't know that we don't do any of that, but our ability through what I would call sort of public health measures to improve people's health has a mixed history. We've also, I think, learned a lot about the origins of some of the behaviors that lead to the health conditions you describe, and they're more complex. We've long sort of stigmatized the behaviors that lead to people having a high weight or behaviors associated with substance use. And the more we study, the more we realize that the origins of those behaviors and conditions often are rooted in trauma. They may be rooted in genetics. They may be things that people have some control over, but not as complete control over as we think. And so I think we do have to be careful. We have a very high burden of mental health disorders and untreated or undertreated mental health disorders that can contribute to people not doing things that we might think are obvious that they could take care of themselves. We have very poor access to healthy foods. Talk about advertising. We should talk about the advertising for all the unhealthful foods that create those health conditions. So I think it's a balance. I believe that most clinicians ask and try to convince their patients to adopt sort of, if you will, lifestyle changes, but most clinicians actually aren't trained in how to encourage people to do those kinds of things. They can just sort of exhort them, but that doesn't really tend to work. So there is no question, I think, that we could do a lot to improve the health of the population and reduce the need for pharmaceuticals if all sorts of other behaviors were improved. But we also are who we are, and when someone is sitting in front of you and they haven't been able to achieve the health gains that you want them through the other practices, and there is a medication, it's hard to think, well, that shouldn't be available to them.
Well, I'm not so much saying that. I mean, I guess that's the pipe dream that everybody who exercises and eats vegan kind of dreams about, and obviously it's not true, but there could be a lot more of that. And I guess it's not at the doctor's office necessarily, and it isn't really part of this cast, but it does seem that to take 5 medications or more for all these different things that are wrong with you is an awful lot.
Well, it is, and clinically also.
Difference,
Yeah. I mean, I think we also have a growing understanding, first of all, the interrelationship across a lot of these diseases and the risks for patients taking multiple drugs that are usually tested and examined as individual drugs, and this notion of polypharmacy and the possible drug-to-drug interactions. Often you find people over, sedated and over medicated. Those are definitely poor outcomes, and some of that can be addressed by what we've just discussed. Others require better medication management, which again, good clinicians will do, but there are opportunities for people to be taking drugs together that they shouldn't be. We know there's a lot of overprescribing that's not medically indicated. All of those things would be good for everyone if we could address them.
It always comes back. It's always the same circle. It's complicated, which no, truthfully is.
It is.
I wanted to ask you about the Orphan Drug Act, which I had never heard of because I guess I didn't need to know about it and until somebody I know ran into needing a drug that had been developed under the Orphan. Then I just kind of realized that there was a good reason for this when it was passed, but it seems to me, again, it's being manipulated.
I think you captured accurately. The Orphan Drug Act has very understandable origins that particularly fit the market-based model that we have for drug pricing. it, like many other provisions, has aspects that once you become a sophisticated reader of the law, you can manipulate to ends that are not so positive. So the concept here is fairly straightforward, which is that a drug company makes money by selling a drug, and if there's a condition that's not very common in the population, then there aren't so many people you can sell the drug to. And if you can't sell it to that many people, you're not going to invest in the discovery necessary to create the drug. So we need to make it more enticing for you to do so. And in order to do that, we give you a period of exclusivity, and we give you some accelerated approval processes so that basically the cost of developing the drug goes down a bit and the revenue you can obtain from the drug goes up a bit. And hopefully at the margin, that makes you more likely to do that type of discovery. And then conceptually, all of that makes perfect sense. The challenge is that the benefits associated with being designated an orphan drug are so potentially lucrative that manufacturers have figured out ways to apply the provisions of the law to things that aren't really what the people had in mind when the law was passed. And that then comes out of the pocket of the consumer, who has to pay extra because those protectionist provisions, which were designed for one purpose, are now being applied elsewhere. And unfortunately, this is standard fare in this sector. And I wouldn't say it's just a pharmaceutical issue, although the intellectual property rules are so dominant. I think it happens more than in other places. But every time we say, oh, we want to increase the incentive for drug investigation in this area, we're also saying, if you can figure out a way to apply that elsewhere, then you're going to make some money off of it. And that is how it works.
The original reason for it is, as I recall reading, was families kind of got together and brought pressure because one of their loved ones had some disease for which there was literally nothing.
Right.
And then and in the beginning, I think those were the drugs that were turned out, diseases that most people never heard of, but there was nothing for them. And in those cases, I believe, excuse me, most insurance companies will pay for the drug.
Oh, right. I don't think this was so much a payment issue as the incentive for discovery. And again, in a market model, you have to convince these companies and the people who invest in them, really, that it's in their interest to try to work on this disease. And obviously, if you can come up with a drug to address Alzheimer or diabetes, you've got a huge market for that. And so the incentives for doing it are really very clear. We have a very different problem. I know it's not the focus of the conversation around antibiotics, where people don't take them, for the rest of their lives. You take them for a short spell, and then you don't take them anymore. We have similar issues around vaccines. So you don't have volume. You don't have the volume reward around antibiotics and vaccines that you have around chronic conditions. And yet we need those medications desperately. So again, you need a different financial model for antibiotics and vaccines than you do for diabetes or cholesterol.
Place where the government might step in.
And it does, and it has. That's right. Exactly.
Just to kind of wrap it up here, I think, all of these issues are different issues and all of them are related. But is there really anything? I mean, suppose we got, this is pure blue sky and nothing to do with the current election, but suppose we got a president who said, my main goal in life is going to be to push drug prices down really quickly, somehow, without beggaring the drug companies, but so we're not beggaring the patients also. Would there be any fast way to do that would be fair?
Well, so I'm going to go back to this notion that there's the price and there's also what people pay. We could dramatically improve drug coverage, and we have. The Medicare Part D that you described used to be pretty skeletal, and then had the donut hole, and we filled in the donut hole. It had no catastrophic limit. So if you had an expensive drug, you could pay. Now we've put in a catastrophic limit. We've actually dramatically improved the Medicare drug benefit. So even though prices are high, coverage is better. Of course, Medicaid coverage is very comprehensive. Private coverage is highly variable, but moving prices is complicated. Subsidizing coverage and improving coverage can be done very quickly. It's just quite expensive. On the pricing side, I think that we can have people can have varied views about the pacing of the Inflation Reduction Act provisions designed to lead to Medicare drug price negotiating. But basically, we're trying to see if we can get the federal government to do what is commonplace around the world, which is, have systems in place to negotiate drug prices, and that's helpful. And then there's a whole raft of activity in Congress right now targeting the PBMs, the pharmacy benefit managers, which affect private insurance coverage for drugs. And these are very opaque organizations. Again, you can go back to their origins and they totally made sense. Now they're playing roles that are a little hard to define and making money in ways that are sometimes we just can't even tell quite how they're doing it. Their incentives are misaligned with the payers. So we're seeing at least calls for transparency and potentially reform there. So the challenge in the U.S. for the president, the mythical president you described, is we do not have one pharmacy market, and therefore it's not a product that you're trying to lower the price of. We have many different kinds of drugs paid for by many different payers, covered by many different types of insurance. And if you want to address this problem, you actually have to solve about 10 or 15 different ones.
All right. Since we probably can't do that on this podcast, is there anything else you think maybe we should talk about?
I think we've covered the topic quite nicely. It has its origins in the notion that we need there to be financial incentives for the industry to invest in trials and getting drugs out there. And once you make that bargain, you have to have revenue streams. And once they're revenue streams, there are people trying to maximize them. And as long as that's sort of the ecosystem we operate in, we're always going to be looking for the pressure points and trying to overcome them. And then we also have to look at the patient side and acknowledge that a lot of these drugs just inherently are going to be expensive. And so what people need is good insurance. And you can try to reduce the price all you want, but at the end of the day, what we need to do is help people afford what is inherently a very expensive medication, and that requires insurance coverage.
All right. Well, thank you. I'm going to wrap it up with that. I appreciate it very much, Alan. And I guess we won't solve it all today.
Probably not, but it's great to have a conversation about the many dimensions.
So, as you and I have both learned, simplistic ideas of how drugs should be priced just don't seem feasible in the U.S. system, although Medicare's new mandate to negotiate some drug pricing may force some overall changes. My thanks again to Alan Weil, editor-in-chief of Health Affairs and podcast host of A Health Podyssey. If you're interested in health policy, as I am, check it out. You'll learn a lot, and there's a link in my podcast page, the episode notes. My next podcast subject's not quite set yet. Just as soon as I know, there will be a note on my podcast page. I schedule one new podcast episode a month, so look for this next episode in January. Usually the podcast drops on the third Tuesday of the month. Updates wherever you get your podcasts. I'd really appreciate it if you would subscribe and, of course, share. We're on Apple, Google, Spotify, TuneIn, iHeart, Podchaser, and my host platform, the Podbeam app. The video version on YouTube. Show notes and links on my website, www.stephanieshelton.com/conversations. And if you like the podcast, it would help a lot if you'd give it a review or give us a rating wherever you watch or listen. I'm Stephanie Shelton, and until we meet again, please take care of yourself and all those you love. Conversations on Health, How We Get There is produced and edited by Frank Harold. Research assistance from Dr. Richard Saltman, Professor Emeritus of Health Policy and Management, Rollins School of Public Health at Emory University in Atlanta.